2025. I think it's a very, very important topic, need of an hour. We all come around with a pain in the body, muscle pain, joint pain, orthopedic pain. So we don't know who to see. So the topic today is it is just joint pain, or you should consult your rheumatologist. So to talk about this topic, we have a doctor joining in from Ganga Hospital. Dr. Lieutenant General Ved Chaturvedi. He's an MBBS and MD General Medicine doctor, DM Clinical Immunology. He's a senior consultant, professor of Clinical Immunology, Department of Rheumatology and Clinical Immunology, Shri Ganga Hospital, New Delhi. One of the India's very few DM qualified rheumatologists, over 37 years of service in senior most clinical immunology in the Army Force and Army Hospital Research Referral in New Delhi, completed DM Clinical Immunology Rheumatology and from SGPGI Lucknow in 1995 after MD General Medicine and MBBS degree. His held leadership role in past president of Indian Rheumatology Association, president of Delhi Rheumatology Association, vice president of APLAR, vice president of MSK Ultrasound Society of India, recipient of prestigious awards like Param Vishisht Seva Medal, Atal Swasth Bhushan Award, Seva for honorary surgery to the President of India. Sir, over to you. Thank you so much.
Thanks for a nice introduction. Just for the basically, I'm a rheumatologist with many years of experience, and after Army, this was Army Hospital. On fifth floor was our Department of Rheumatology. That time when people were fighting what is rheumatology, so that is what the time, and a lot of slides were made that time to tell the administrators also, okay, what is a rheumatology, because we were the few first DM in the country, and I was in uniform that time, and then reached to the highest rank of Lieutenant General, and after retirement now I'm working in Gangaram Hospital, equally prestigious hospital. So about pain, if you have more joints, you'll have more pain. So that is how this cartoon says. So much research is done cardiology. Unfortunately, last so many years there was no research in rheumatology except in last 2 decades. The whole things have changed, and the mobility is very important. I always feel if mobility is affected, then it is paralysis. One paralysis we all know, paralysis because of brain, but paralysis because of joints is also, and it's a painful paralysis, unlike the brain paralysis. Not long back, you will not believe, my mother had arthritis, and she was treated not by this, but by frog. So what they used to do, they used to take the frog and put it on the. So that was the treatment. So world over, the treatment for arthritis was not there. A lot of people ask me, is it curable? Even today, ask me what is curable. So the research is gradual. It is something like just like research in hypertension and diabetes. We can definitely control the arthritis, and if you control the arthritis, then you can prevent the joint destruction, and you may not need surgery. So that is the prevention of surgery is very, very important if you show to a correct doctor. And arthritis is inflammation, and this inflammation is virtually lifelong. What a misery. So it's a whole life inflammation, and that lead to a lot of other issues like amyloidosis and other issues. So it's a lifelong inflammation unless it is controlled. And our main goal is this. And uh, this quote is from Dr. Ravinder Mani, which I had called him to Army Hospital, that in the parties, you can see a patient of diabetes, you can see a patient of cancer, but you will hardly find a patient who has a arthritis, because they may not die, but they vanish from society. So they are not there. So if they are not there, they don't say they are. So they can't tell their story, so the research was poor. A person from cancer will say 100 places that I have cancer, and people will have a lot of societies, this, that. In rheumatology, they simply vanish from society. If my wife has arthritis, probably she will simply stop going to parties and socialization. So that is how the problem is. Rheumatology, what is rheumatology? The topic is whom should be referred to rheumatologist. And so first we should understand what is a rheumatologist. So it's not only the joint diseases. So the topic is very apt that it's not only joint, it is a few muscle diseases, few immune mediated diseases, and body framework disease. And what is a body framework? The body framework is, body is not only made of the joints, and the framework is not only of the bones. Of course bones are there, joints are there, but it has a lot of soft tissue. Now this soft, lot of muscles, lot of blood vessels, lot of nerves, and if they are involved in immune inflammation, so it makes a huge. So that's why the rheumatology is not called as joint disease, jointology. It is rheumatology is a word which came, basically, this word of rheumatism is used by Europeans for aches and pains. So anything which is causing aches and pains, starting from joint, muscles, any inflammation, and basically we learn over a period of time that this inflammation is mostly immunological origin. And that's why whole research was done in immunological disease. Of course mechanical cause can cause also, like suppose you have a pain in the joint. Now joint pain can be because of many reasons which we'll discuss, but the most important thing which we treat is immune inflammatory diseases, whether they belong to the they are affecting the main target, may be joint, main target may be muscles, main target can be soft tissue, main target can be blood vessels. So joint diseases we call as arthritis, the muscle disease we call myositis, the blood vessel diseases we call vasculitis, and soft tissue are connective tissue diseases. So joint pain is very common but not always harmless. Early diagnosis of rheumatic disease improves the outcome. Rheumatologists specialize in autoimmune and inflammatory joint diseases. The common cause of joint pain is assigned mechanical. Mechanical means, suppose I'm old person now today and my joints had wear and tear, so I have little pain, so that is called mechanical pain. So that, or suppose I get an injury, suppose a cricket ball hits me and it hit my joint, and that is a mechanical pain. So because of the, and we call it osteoarthritis. Inflammatory pain is diseases generally. So there are many diseases which affect the joint. They are inflammatory diseases, and there are some example like rheumatoid arthritis and lupus. Infection can, of course, involve any tissue. So infection can be, and metabolic, of course, and you can add on to degenerative and genetic diseases to this. Basically mechanical pain, as I said, suppose I'm an old person and I have a pain in the knee, and if I am sitting here I have no pain, but if I move then there's a pain. So pain after exertion, which improves with the rest. If I sit on my chair I don't have pain, so I walk. If I climb stairs then I have pain. So but if I sit on the chair it improves, and it localized to one or two joints. And generally, there is no swelling, there is no stiff diseases. In rheumatology, is osteoarthritis, which goes to everybody, whether it's a rheumatologist or an orthopedic surgeon or uh, the another pain is inflammatory pain. Now, this pain is an important pain. So, one is a mechanical pain, another is an inflammatory pain. Now, inflammatory pain, the biggest hallmark of this disease is a stiffness. You can call it morning stiffness, I call it rest stiffness. So moment you take little rest, then your whole body becomes stiff. And if you ask patient, he will say, doctor, I have a lot of stiffness when I get up in the morning or if I sit for a longer time. And so that is a significant stiffness. Means if you get up in the morning and it about for about this much time, or 30-35 minutes, you are unwell, probably it is significant stiffness, and it is also associated with fatigue and weight loss, and the it has rash, ulcers, and other issues can also be there. But just remember, there are two types of pain. That one pain is mechanical, which I told you, osteoarthritis, old age arthritis. Another pain is inflammatory pain, which is actually is the autoimmune nature. It's the immune inflammation. The hallmark of this is basically a morning stiffness and fatigue and fever. There are many diseases, autoimmune diseases, which we go. Role of rheumatologist is basically diagnosing these diseases, autoimmune inflammatory condition, and prevent joint damage and coordinate the long-term care. There are a few tests which are done, which we'll discuss later. What is the benefits of early referral? The benefits of early referral is the prevent the joint damage. So it is like referral in cardiology. If you have chest pain, go to cardiologist. He will assess you and do either a stenting or no, anticoagulants or thromboplastin, and then basically to prevent the damage of the heart muscles. So damage the joint, prevention of joint damage. So if you go to a rheumatologist, he will give you a drug which will prevent the joint damage, and basically it improves the quality of life, and avoid misdiagnosis and delays. There are a lot of misdiagnosis and delays, and quality of life is also a very important term. Look, if you keep telling every day that I have pain, nobody is going to listen. So, and your work work is affected. A lot of people. I was in army, so if somebody had chikungunya and a Kerala unit, and that time the defense minister was George Fernandez. He told me to go to Kerala and see. There's one NCC unit where everybody's down with the. So I when I went there, I was surprised to see the whole village and all workers, including the NCC battalion and army battalions, TA battalion. So their quality of life was so poor. So once we treat them, the quality of life become better. They can attend the office. So work absenteeism can also be reduced. There are a lot of myth about the joints. One is a joint pain is because of aging. A lot of people, once I joined rheumatology, I was posted to Guwahati. First, I was posted to Calcutta after DM. There's a big hospital, Army Hospital, Calcutta, almost 1,000 bedded, huge, big hospital, modern hospital. One of the first few rheumatologists in the country. So they said, my boss was a physician. He didn't know much about rheumatology. He says, we don't. I'm very sure you're joined rheumatology because you want to treat some senior people, journalists and all. At that time, I was a major, lieutenant colonel. So a lot of people feel probably it is for old age joint pain. No, our 90% patients are young. Immune inflammation is common in young population, while mechanical pain or degenerative disease is common at my age. So if our most patients are young, so that is one myth. Young people. Uh, Generally, a lot of people say if there is no swelling, don't worry. No, inflammatory pain can also precede swelling. So a lot of, if you go to a physician, if you go to a doctor, even rheumatologist, he said, "No, there's no swelling, don't worry about it." But no, it can be an initial phase. It can be a onset of the illness. So a lot of pain, a lot of ladies comes and sometimes people say, "Don't worry about it. You don't have anything. Probably you are having the stress." No, investigate them. Then you say, so investigate, and a lot of people feel that they need surgery, they go to surgeon. So everybody doesn't need surgery. If there is a joint total damage and your quality of life is poor, then surgeon offer you the surgery. Beyond the joint, suspect there are is whenever patient comes with joint pain, we ask a lot of other questions also, and which I'll tell you why we ask. So we ask the it's a connective tissue inflammation. So if autoimmune diseases, they can attack the joint itself, they can attack the synovium, they can attack the soft tissue. Soft tissue is a connective tissue, which is present between the cell, and it is ubiquitous in nature, starting from hairs to the toe. Connective tissue is there. Like somebody asked me, where is the heart? So heart is here, but where is the connective tissue? Now, connective tissue is present in the hairs, eyes, nose, teeth, gums, thyroid, heart, lung, ovaries, intestine. So, connective tissue is present all over. So, it can be inflamed, and that's why these diseases, whenever the joint pains comes, we always ask head to toe, are you losing hairs? Because we are searching for connective tissue in the hairs. A red eye you have oral ulcers, you have thyroid inflammation, you have carditis, you have pleural effusion, you have lung effusion, you have interstitial lung disease, you have abdominal issues, you have skin issue. A biggest source of connective tissue is skin. So that's why they are multi-system diseases. So you can have a skin rash, you can have a lung problem, you can have kidney problems. So a lot of people ask me, "Yeah, what is this specialty?" Cardiologist is worried about heart, lung specialist is worried about lung, eye specialist is worried about eye, and you are worried about head to toe. You are asking so many questions. So that is because of the multi-system nature of the disease, because of the ubiquitous nature of connective tissue. Connective tissue is present all over, so all systems can be involved, and of course they can have fatigue, weight loss, fever, and some markers of autoimmune diseases, and they can have family history also. So you consider all these patients. So multi-system diseases beyond joint pain. Everybody knows about joint pain. Now, joint pain are supposed to be referred to rheumatologist, but the art but the if you have a multi-systems involvement, and you are thinking that it can be autoimmune disease, that can also be referral. And I always advise patients at least that you keep a diary of symptoms. It may be less important for a other doctor, but it's very important for rheumatologist. Somebody says, I have red eye also, I have dry mouth also, I have hair fall also. So basically keep a symptom diary and list the medication, allergies, uh, lab test, and family history. Don't ignore persistent joint pain. And inflammatory arthritis needs early treatment. Rheumatologists manage complex autoimmune disease. Referral, early referral has a better outcomes. And this is the body framework which I was telling you, which now I'm coming to soft tissue. Now, soft tissue, which we always call it soft tissue, is always also called as connective tissue. So that's called connective tissue diseases. So connective tissues diseases, in the short form, they call CTDs, connective tissue disease. They are also called soft tissue diseases, soft tissue rheumatism, interstitial tissue like interstitial lung disease, or extracellular matrix. So basically, all are the most popular word is connective tissue disease, CTD. That is how the scientifically we call it connective tissue diseases. And connective tissue diseases are few. Now, if even if you don't remember the name, just remember the connective tissue disease and how they are diagnosed. Beyond joint pain, this immune inflammation can attack anything. It can attack your joints. So joint pains are has been highlighted. So a specialty has been made. But otherwise, they can go to an eye specialist because of red eye. They can go to a ENT surgeon for a recurrent oral ulceration. They can come for to the skin specialist because of rash. So multi-system, as I described to you, they can have a pleural effusion. They can have a effusion around the heart, pericardial effusion, or maybe lung involvement. All these diseases, we call it the system complex has been grouped. One group is called SLE, another group is called systemic sclerosis, and some CTD, I told you, connective tissue disease. If there is a mixture of symptoms, it's called MCTD, mixed connective tissue disease. And we are not sure what it is. We call it undifferentiated connective disease and Sjogren syndrome. So there are few diseases which also needs referral and attention of a rheumatologist. SLE, most of the doctors and most of the people, laymen, understand by this rash, which is a butterfly rash. But this has been highlighted. Others has not been highlighted, like alopecia, hair loss of hairs. involvement of kidney, proteinuria, lung involvement, pleural effusion, interstitial lung disease, lung hemorrhage, hematology, the factory is not working, so or a lot of cells are destroyed, so they have low hemoglobin, they have low platelet, low cell count, heart pericardial effusion, abdominal also they have ascites. So multi-system disease, if you have a patient who has one of these symptoms, not always everything is there. Unfortunately, most of the physicians probably think that everything is there, then no, there can be a some disease. Basically, maybe patient comes to you with a fever, so you have investigated everything. Patient is running temperature for last 3 months, and then you do a test, something like ANA. So then you realize probably it is. So you're lucky if somebody has a lupus-like rash, then you can pick it up. But there are a lot of other organs are involved, starting from hairs, as I told you, heart, I told you, lungs, I told you, the kidney, I told you, muscle and other things can also be involved. So, and the antibody is important, is ANA positivity, plus a lot of other antibodies like dsDNA and NTSM and multi. So if you see a report, even if you don't know about immunology, if you say ANA is positive in a good titer means about 180, 100 is normally is a cutoff. So if it is positive, and there are multiple antibodies which you don't understand also, then probably, and in the lab also, if you just scan through, it is written beautifully. What is the significance of anti dsDNA? It is written there. Now, most of the lab people, so anti dsDNA is specific, anti-SM is specific, but that is a job of a rheumatologist. But nothing bad to learn more. So basically, learn about these antibodies, and they can have lot of rashes and these types of rashes in the skin also. It depends on many. There is another disease which we'll discuss later on, the Sjogren syndrome. Now, Sjogren syndrome is like lupus only. I can tell you, they'll present with everything. They'll present, they may not have the classical rash, but they will present with dry eye, dry mouth, maybe pericardial effusion. They can present as a lung effusion. They can have proteinuria, and but the classical symptom is dry eye and dry mouth. So this is called Sjogren syndrome, and we call it Sika symptoms. But they can also have multi-system abnormality from here to here. The biggest problem with Sjogren syndrome is that it is a lymphocytic infiltration of the glands and other tissues and neuropathy. I forgot to write neuropathy, which is important. Generally, come with the and the dry eye, dry mouth. This is the Sjogren is a German scientist. So dry eye, dry mouth, and it's not very specific, but these antibodies suggest SSA, SSB. So you do ANA is positive, SSA, SSB, and they are generally diagnosed by lip biopsy because lips have a lot of glands. So you do the lip biopsy because the biopsy of submandibular gland or subparotid gland is difficult. So this is how the biopsy lymphocytic infiltration you can see, and these are the glands which involve parotid, and the submandibular and the sublingual glands are involved. And the
खाना भी डाला था ना इसको
then please switch off the mic. Yeah. So, and they can have a lot of involvement of many other tissue like joint, like SLE only. They can present as arthritis, lung involvement, kidney involvement, vasculitis, ulcers, neuropathy. And so remember, these diseases are multi-system diseases. And the clinical features also depends on which tissue is involved. So you should be a very good physician before becoming a rheumatologist, whether the hairs are involved, whether the eyes are involved, whether neuropathy is there. And as I said, diagnosis by lip biopsy. So this is a dense lymphocytic infiltration. This normal, this is how it is, lip biopsy. And another disease called systemic sclerosis. Now, sclerosis means thickening. Systemic means all systems are thickening beside the skin. So this disease called more fibrosis in the connective tissue. In the skin, you can see it, but it is happening in the lung, it is happening in the heart. So sclerosis, which is systemic in nature, and they have vasculopathy. because of vasculopathy, they can have Raynaud's. So they present with the Raynaud's, and repeated Raynaud's will cause little ulcers because of the ischemia. So they have little ulcers, and of course lungs involved. Similar pathology in the esophagus is also getting thickened, so you have dysphagia, and stomach becomes small, so you have a lot of regurgitation, and GI tract can have even an intestinal obstruction, and of course heart also have little conduction abnormalities because of fibrosis. So they have, this is basically the fibrosis, and this is called purse string appearance of the lip. It is basically because of fibrosis. So fibrosis here, fibrosis here, fibrosis. So you can see the skin thickening. You can feel, the patient will not tell exactly, but you can always that, yeah, this is the patient may say that my skin is little. They have their own way of describing it. And distal ulcers, which I told you, because of the basically because of the repeated Raynaud's. Raynaud's is basically a the excessive hypersensitivity of the blood vessels to the cold. So even a little cold is there, it goes in contraction called Raynaud's, and repeated Raynaud's will cause these ulcers. So that is how. Another disease is hypermobility. Now we must learn this, because a lot of patients, it is another connective tissue abnormality. The name is hypermobility, but I always put it in the connective tissue abnormality, which is genetic in nature. So if my connective tissue, I can only stretch it up to here, but suppose my skin goes up to here, like my head can only come up to here. But suppose there are people who can put their head right on the back, and like hand, like I can only do it like this, but somebody, so because of the abnormal connective tissue, their connective tissue is very soft and very mobile, very flexible, and they have this, the disease is called as hypermobility syndrome, because there are a lot of other things are there, and each tissue become hypermobile. So how they validated some symptoms and signs, this is one of them. If you tell your patient to do it like this, normally we cannot do it. If there are a lot of people who can do it, this is one of the domain for hypermobility. And there are other domains also, which you can see in the book. If you just go on the net, hypermobility syndrome, and they have abnormal connective tissue. Now, this abnormal connective tissue is not only in the joint and muscles, though they can have a lot of joint pain. It can be in the heart. Sometimes it can be very severe, which is called Ehlers-Danlos syndrome, where repeated, patient will come that this joint comes out, the dislocation, multiple dislocation. So they can come with multiple dislocation. Their blood vessels can be abnormal. Their joints can be abnormal. So they can also come with the another is vasculitis. Unfortunately, because of some technical, the photographs have not come. But you must remember, as I said, inflammation of the joint is called arthritis. Inflammation of the blood vessel is called vasculitis. It can be large vessel, it can be small vessel, it can be very small vessel. So large vessel, medium vessel, and a small vessel. The large vessel vasculitis, which see more in India, is Asia, is Takayasu arthritis, which is called a pulseless disease. So a lot of pulses you may not able to feel, and other symptoms depends on which artery is involved. Normally aorta is involved. So aorta and these blood vessels which is going in the, so aorta and blood, so vasculitis. And classical, you must remember, is this. The another which is seen in the Europe is giant cell arteritis, basically comes with headache and temporal arteritis. Another is the medium vessel vasculitis, which is polyarteritis nodosa, which they comes with neuropathy. And small vessel vasculitis, the list is huge, but the ANCA has is a one test which has emerged. So ANCA associated vasculitis. Probably this is not the, but just remember, the blood vessel inflammation depends on which blood vessel is involved. A lot of people think blood vessels means you can see the blood. No, blood vessels are sometimes in the lungs. The blood vessels, the kidney. So they can present in a different way. It's a highly specialized subject for rheumatologists also. So if you suspect a vasculitis, and they can also have a lot of joint pain. Fibromyalgia, of course, it's a central pain syndrome where you have done everything, but everything is normal, but a lot of aches and pains, and they have fatigue, you always feel probably they have some mental issues. Yes, they are central pain syndrome. So they are central pain syndromes, and they are very difficult to treat. The clinical examination is normal except for the tender joints. So fibromyalgia is itself a huge topic. And psoriatic arthritis, you should not forget. You must ask one question: do you have any disease, skin disease, which is there here? Even I miss even today, maybe in the hairs, maybe in the elbow, maybe near the navel. So psoriasis can cause a lot of aches and pains, which is different from other joint pains, because they are the ligaments are involved, and there are very different types of aches and pains. And I'm very sure a lot of psoriasis is missed because of this. Sometimes, of course, the psoriasis is not there because psoriasis comes later. But patient may not be giving much importance. It happens daily with me also, that sometimes you forget to ask this question, and then after 2 or 3 visits he say, Kirok, I have this also, I thought I'll show you that I have small patch. Oh, I said psoriasis, that your diagnosis is psoriasis. What is the difference between orthopedic surgeon and rheumatology? Why two rheumatologists? Why not two orthopedic surgeon? Our relationship is like something like cardiac surgeon and cardiologist. Like you referred, if I have a chest pain, a heart attack, I go to cardiologist. I don't go to cardiac surgeon. So cardiologist and cardiac surgeon. If I have a stroke, I go to neurophysician, not neurosurgeon. Same as we are joint physicians. So we deal with diseases, while joint surgeon primarily deals with the surgery. Of course, patient go everywhere. Patient goes to MBBS doctor also, patient go to orthopedic surgeons also. But the correct thing should be known that we are joint physicians are called as the rheumatologist. So it is a specialty which is difficult to understand about the rheumatologist is a physician with MD medicine degree or have some degree like DM, like I have a DM qualified, DNB degree, or maybe a 3 years training in rheumatology. Now, there are a lot of issues are there because even a place like Delhi has 100 rheumatologists, a few are DM, a few are DNB, but most of the people are not exactly the way which we want them to train, but they are doing a good job in rheumatology. So they are self-styled rheumatologists, and they are working and doing, because so many qualified rheumatologists are not there. So that is how it is. Arthritis, as I said, probably it's a young age. So our patients are young, and it is a immune in origin. Usually, the infection is more common in the children and the elderly. It's like neurology today. If somebody comes with arthritis, we always see which is the level of lesion. Is it the cartilage, which we call it osteoarthritis? Is it the synovium? This is like a football bladder. It is a skin, and this is behind, inside the skin is a bladder, which is called synovium. Synovial disease is classical rheumatoid arthritis, and tendon and ligament disease is spondyloarthropathy. And of course, in the synovial fluid is the basically a gout. So this is, we call it arthralgia when swelling is not there. We call it arthritis. So inflammatory and non-inflammatory is very, very important, which I already explained to you. This is mechanical pain. When he moves around, he has a pain which called as non-inflammatory. But if somebody has inflammation and all those characters that I have become worse in the morning, and when I move around, I become better, these are called as these are red flag arthritis, red flag signs. This is something like benign and malignant. If a malignant is there, don't waste your time. Show to a rheumatologist. Otherwise, you are missing a bus. So we have to catch it early. Immune inflammation, if it is treated early, maybe curable, definitely controllable. So moment you have a inflammatory arthritis, you just have to ask 3 questions. What happens in the morning? Doctor, I have a lot of problem in the morning. And then I become little move around, I become better. I feel little fatigue and fever. Inflammatory arthritis. Must, it's an emergency. So you must show to a rheumatologist. If somebody has a mechanical pain, like our elderly in the house, that is a mechanical pain. You can still wait. Doctor, I'm all right when I'm sitting. When I move around, then I have pain. That is a mechanical pain. So it is an inflammatory versus non-inflammatory. Then you single versus multiple joints. Single arthritis is generally is taught to us like tuberculosis and other infections and gout. Then multiple joints is rheumatoid arthritis, acute arthritis like gout or sepsis. The moment these things come, and a chronic arthritis, this is a monoarthritis, is a polyarthritis. This is a rheumatoid arthritis, and basically functional disability. So biggest problem with these diseases is a lot of people say, what is so great about joint pain? Yes, they cannot do all this. A lady having rheumatoid arthritis, she cannot sit in Indian toilet, she cannot make her hairs, she cannot put on her undergarments, she cannot tie her sari, she cannot even eat breaking chapati. What about making and husband wife relationship become poor, and that leads to the divorce. And unfortunately they are that time young, and that is the time they are married. Most of the autoimmune disease for some reason starts after the delivery, and that is the time when they become worse, when expectation of family is huge. So it can lead to total joint failure. Hormone research lead to the in the endocrine, while cytokine research was done and in the arthritis, and that changed the game. Of course, mimics of arthritis, which I already told you about, the a lot of associated problems like eye. So you must ask about the eye, you must ask about the nervous system, you must ask about the, and because of the multi-system diseases, because of the ubiquitous nature of the connected tissue, so lung, every tissue you must ask about the question. This is how the big rheumatology, this is how our OPD is conducted, that most of the diseases are fortunately mechanical. So 30% these are mechanical pain. So we assure them that it is a maybe age related, maybe some inflammation, but it can wait. About 9% diseases are inflammatory diseases, and about 12% diseases are soft tissue rheumatism. Simple classification I'm giving you, much easier. If a woman walk to you and she tells that I have a joint pain and multiple joint pain, it could be either rheumatoid arthritis or connective tissue disease like SLE. If a male walks to you and he has a pain in the lower limb and backache, probably you are dealing with the spondyloarthropathy. An old person coming with the joint pain, probably you are dealing with the osteoarthritis. And a child comes, it is juvenile arthritis. That is how you remember that if a woman walks, this is probably rheumatoid arthritis or connective tissue disease like SLE. Male has spondyloarthropathy or ankylosing spondylitis. Male and old people have osteoarthritis. So I always call it arthritis of young female rheumatoid arthritis. Rheumatoid arthritis of young male is spondyloarthropathy, and arthritis of senior citizen is osteoarthritis, and arthritis of children. So the more serious is red flag arthritis. Our respected old the ex Prime Minister Atal Bihari Vajpayee had osteoarthritis. So I was treating him. So I always show this photograph, osteoarthritis. This is called as arthritis of senior citizen, osteoarthritis, and where the joint is space become less because of the cartilage goes away. Cartilage. So this is a cartilage disease, and gradually cartilage goes away. So this is a normal cartilage. You can see a nice cartilage, and this cartilage is seen as a black because it has a lot of fluid in the cartilage. So it is a black, and this cartilage gradually goes away. So it is goes away. So you can see this is gradually become thin and thin. So this is some grading is there. Forget about grading. Just remember, it's a gradually the cartilage goes away, and it's a total joint failure at the later stage. So it's called late disease. And this is, of course, rheumatoid arthritis. Arthritis is young females. And if you don't treat, they become like this. So today it's a treatable condition, 100% treatable condition, rheumatoid arthritis. They present as a polyarthritis in a female, which is a lot of morning stiffness and involvement of mostly the small joints of hands. And this is the male disease, which is a spondyloarthropathy and ankylosing spondylitis. A male, young male will come with a backache and joint pain, especially in the lower limb, which is the, and either a back pocket pain or a side pocket pain. Because I was in army, so I had a lot of interest. If you don't treat it at this stage, they become like this. Today, biologics are given, And osteoporosis, of course, everybody knows. They can also have little pains, aches and pains, but generally they don't have aches and pains. So osteoporosis is also where the bone density become less and they're prone to fracture. This is a normal bone and this is a osteoporotic bone. So they are prone to fracture basically. So basically it's a fracture preventing strategy. Gout, of course, people used to call it rich man's disease, but earlier, nowadays everybody is having a high protein diet, meat and drinks, high calorie, less of the activity, physical activity. So this is the classical gout which presents as the first MTP. Other joints are also involved, and this is a cause of this disease. And young children, we call it juvenile arthritis. So this is juvenile arthritis. It affects the whole family actually, and if the child is affected, and these are the diffuse connective tissue disease which I've already told you. The diagnosis of diabetes is done by blood sugar, while the kidney is failure is diagnosed by urea creatinine, and malaria is diagnosed by malaria parasite. Unfortunately, there is no gold standard test in rheumatology. A lot of tests are there, starting from rheumatoid factor. There's that, but that is the a different topic altogether. But there's not a single gold standard test. If you have not taken the history properly, then the probably. So I stop here. I'll not discuss the treatment, but ladies and gentlemen, to this earlier, this is how the this pyramid is going on. That are for last 5,000 years, aspirin-related drugs came, then other painkiller came, then better. And the research is on the multiple cells. They talk to each other, something like this. They talk to each other, and then you stop this, and that's how the all these drugs can come. For many years, there was nothing. Then came the gold, hydroxychloroquine, methotrexate, lefenamide. Now, the calcium, glucosamine, viscosupplementation, and now biologics. And this is the last slide which I'll show because there are 100 more. That the steroid still remain a very important drug which was discovered by the
So I think we have lost the connection for the speaker. Uh, I think till the time he joins back, I would like to invite Dr. Chong. Oh, he's back. I think you lost the connection, sir, on the last slide. You're muted, sir. You're muted. You need to unmute yourself.
basically, to summarize, rheumatology for last 50 years or so has emerged as an important specialty, and for knowledge of others, those who are in the those who are chairman of selection committee and all today, if there are, say, there are 200 seats in the of super specialty in the country, the first toppers now going to rheumatology because so much rapid development in rheumatology. So rheumatology has come in a long way, and today most of the new drugs are coming in rheumatology. Well, like something like I can tell you, there are so many drugs is sold in America. Humira is a drug which is sold. Adalimumab is the highest selling drug combined together of all the drugs, is the highest selling drug. So you can imagine what is happening to rheumatology today. The treatment is available. Like neurology, a lot of treatment is not available. You can diagnose, but the treatment is breakthrough is not there. A lot of breakthrough has become in immunology. Thank you so much. Thanks.
So thank you so much for the wonderful session. I think it is a very good session to open eyes for people who cannot differentiate between what pain it is. It is a muscular pain, it is a arthritis pain, it is a rheumatological pain, or whatever it is. So I would like to invite the forum for asking question answers. Uh, Dr. Chong, over to you. Okay, so Dr. Chong is cannot unmute himself. Oh, sorry. So sorry. Okay. I realized that. Okay, I'm so sorry. I had to force mute everyone because of somebody did. Now you can unmute yourself. I've never done that before, so I didn't realize. Sorry.
So I
Hi,
have
Dr. Chaturvedi. Thank you very much for your very succinct and very comprehensive review of rheumatology. It's always a very difficult area of medicine because, anytime you try to diagnose diseases with criteria, you're always in a very difficult area. And I always say that it's like a giant universal set of autoimmune disease, and you're trying to draw little subset circles inside using criteria, and sometimes you capture a lot of the patients, but invariably some of the patients drop outside the subset. So this is always a very, very difficult area for all of us. And when they don't follow the sets, the subsets, then you get a lot of problems. I also like to ask, these new biologics that have been just coming onto the market, there's so many of them now. Is there any rational way of using them?
Yeah, in fact, I was the first person in this country, huge country, which used biologics, and I was the only one used all alone for 10 years. So because it was so costly, I was in army, and army could give it. So I was formally educated in rheumatology. I landed in hospital which had all these biologics, and I'm telling year 99, where Ravindra Mani was the first person who published the paper, and I called him. He was surprised that we have already have medicine, and rest is a history. I presented in APLAR, I presented in ACR, biologics, and people used to ask me single question: who is giving you such a costly drug? So I said Indian Army. So that is how we had highest experienced person in this country for the biologics is me, and I always feel it's not that everybody should be treated with biologics. Since they are costly, we should always use traditional drugs first. And about 99% patients can be taken care of the traditional drugs which we have, methotrexate, leflunomide, sulfasalazine. Yes, if they don't respond, then we go to the biologics. And there are a lot of biologics, they are used differently. Sometimes they are called anti-TNF, against cytokine anti-IL-17, and TNF also. So it's a topic by itself. We'll take it once and make it very simple that how the research is going in direction of biologics.
So, Dr. Chaturvati, I guess you are looking at patients who don't respond to your traditional drugs of rheumatology, then you start thinking about biologics?
I'll tell you, in spondyloarthropathy, in axial SPA, you don't have a single drug which can work for axial SPA except biologics. So, since my interest is axial SPA, all my 10,000, 20,000 patients are on biologics only. Because
Oh,
for spondyloarthropathy, you don't have any drug, neither methotrexate, not sulfasalazine, not leflunomide. For ankylosing spondylitis, when axial disease is there, the only treatment is biologics. Like so many things, like vasculitis. Now, if you have vasculitis, ANCA-associated vasculitis, CMAAO or by other drugs. So there are a lot of situations, but exclusive situations are there. It's a huge topic, which biologics for which patient in which direction. As on today, because of the cost, I'm very sure if the cost is not the factor, they are the most effective treatment. Suppose I'm a very rich person and I feel that I have a rheumatoid arthritis. So I would like to be treated with a drug which acts faster. That is number one. And it has a lot of efficacy. So biologics fits into that. But those types of trials probably are not there because of regulators. Regulators feel that you must use the traditional drug first. And if they don't respond, then you come to biologics because of cost.
of course. Yes, thank you. So when you say axial diseases, you're talking basically ankylosing spondylitis?
Yeah, axial SPA. Yeah,
Hmm,
ankylosing spondylitis.
I see. Thank you. Any other questions on the floor for Dr. Chaturvedi? We have Dr. Anjali.
Good morning, Dr. Chaturvedi.
Good morning.
Thank you so much for this important topic. I'm very much happy to listen to you about this hypermobility and Ehlers-Danlos syndrome. So I'm treating one of your patient. I'm based in Hyderabad, and she's been doing telehealth from me. I think she's seen you in Delhi for the diagnosis of EDS. So my question to you is, if I have to refer patients to you, can I do that? Because there's hardly any awareness on hypermobility in India as of now.
You'll be surprised the amount of diagnosis we have done. I remember a, 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 a home secretary of this country in about 10, 10 20 years back, and he used to come with aches and pains, and I could not diagnose. I was young that time, much younger. And one day he will always come to me. He says, "Look, I have a lot of aches and pains." I told, "Look, you are from Home Secretary. You are a lot of stress." One day he came shots,
You're breaking up a
and I
lot.
was standing like a child. Hyperextension of the knee, and moment I say, "Look, you have diagnosis now." So since then I'm catching hundreds of hypermobility syndrome, and I'm missing hundreds. That is also true in a busy OPD, and it's a very important cause of aches and pains and joint pain. And you must, and extreme there are different cities. I have a Ehlers-Danlos syndrome group, so I still remember. And my first patient when I did my DM and was posted to Calcutta was a Naga lady who was referred to me that she has aches and pains. And I was asking her detailed history like a youngster. Then she told me, "Look, I am admitted repeatedly in different hospital for dislocations." So then suddenly I remember, oh, this is the Ehlers-Danlos syndrome. From that time till now, it's a very fascinating field, wide open for research. Nobody has done anything, frankly speaking. They suffer, these patients.
True, doctor. Thank you so much.
So,
Is arthritis can be cured? Oh, okay.
Oh, I think we've lost him, Sarab.
Yeah, I was just realizing where's the face gone. So I think yeah. So if we let's wait for him. But I think it's a very good topic. Just because a lot of people get confused on what pain and who to consult. So in fact, this is a topic which came from a patient who had been struggling for many years in terms of they were showing to the to the orthopedician and just general physician, and they never referred to the rheumatologist, and finally when they referred to the new rheumatologist, they had a relief from the pain. So I thought this is one of the very important topics we need to cover.
Yes,
So
indeed. Yeah. It's a quite a neglected field of medicine.
yes.
Yeah. So
In fact, I was telling Dr. Chaturvedi that we are running a national NGO by the name Myositis India, and we do get a lot of patients. It's a free of cost kind of OPD for patients who are suffering myositis or arthritis or rheumatological problems. And we get patients every day, left, right, and center, being neglected, being not not treated from the right person. Yes, they do have relief, but the relief is not which is supposed to be. So we have Dr. Chaturvedi back, uh, the man walking in Gangaram Hospital. That's the life of a doctor, I would say. Sir, you're muted. You need to unmute yourself. Dr. Chaturvedi, can you unmute yourself? Yes.
Just hold on for 2 minutes.
Absolutely. We are having a 0 hour, so that's fine.
Just a minute.
So I was talking to Dr. Chaturvedi before the session started, and we're getting a lot of patients there. And it's a very neglected field, and I think we should cover more topics later on. Apart from the public questions, do we have any other questions? They can come forward as well. I think Dr. Chaturvedi is walking from corridors of the hospital.
Dr. Saurabh sir, you said that you are having some free clinic for myositis patients. So can you please send it? How can we refer the patient over there?
You can visit the website name as myositisindia.org.
Okay. Can you
There
please
we have
write down as well? I may not
I will
miss
do that.
anything.
I will do
Okay.
that.
Thank you, Dr. Saurabh.
I think we've lost him again, Saurabh.
Yeah, I think he's just walking on the. Probably, I think he's going towards the internet area because hospitals have a very difficult network in India.
Yes, that's right.
So we can just wait for a couple of minutes, otherwise we'll close the session.
Yes, let's do that.
Okay. Yeah, I think we can cover up those questions in the next session. We would like to invite him as well. I'm sure he's taking a lot of pain to get connection, but hospitals are hospitals.
Yeah.
So what do you say, Dr. Chong? Oh, he's here. He's here. Just give me a second. He's here.
Yeah, so I thought of telling him bye-bye because what has happened. But good to see Saurabh and other people, Anjali and Dr. Chang. Sorry for my poor knowledge that you are from, Dr. Chang is from?
Dr. Chong is the chairman for CMAAO. He's in Singapore, and I will let him speak for that.
Thank you, Dr. Chaturvedi.
Yeah, last conference of rheumatology was done in Singapore. The Asia Pacific conference was since I'm general secretary of that. So Singapore, I saw a few hospitals. Went to the Singapore and saw a few hospitals how they work in rheumatology. So that is the. So thank you so much. So
just to add, Dr. Angelique and Dr. Akhtar Hussain is here from South Africa. Dr. Mukti is here from Nepal. We had Dr. Naidu from Malaysia. He's just left. Dr. Sanchita is from IGCP Delhi. Dr. Anjali is from India, Hyderabad. And we have all other doctors. I can't recognize the name because it says iPhone or Samsung. So Dr. Samsung and
Thank you, Dr. Chaturvedi, and much appreciated that for your presentation today. And I think we've come to the end of our session, and I'd like to thank you again and welcome you back again another time to discuss more about rheumatology. I think it's
Thanks.
often an under-neglected area, or rather neglected area of medicine that we all want more information on.
Thank you. Thank you. Thanks.
Thank you very much. Thank you, sir.
Thanks.
Thank you so much, sir. Excellent presentation, and we'll see you